hope you're all doing good. Welcome back to our B2B YouTube series, where we are talking about the modules, what you need to be doing, what you should know, and how to prepare. So today, my module is labor board. That's actually the labor module, where all of you would be getting only one case there, which is labor board prioritization. So yes, guys, in this probably short presentation, I'm going to take you through the basic tips which you should be doing and which you shouldn't be doing as well. Definitely, this is an everyday thing which you are doing at your own practice, but there are few things which you need to know, which you need to be aware, and which you need to do during these 10 minutes. There is no escape for this station. Everybody has to get it. So let's dive deep and see how we can make it better for you. One thing I always say that if you're doing the same things every single time, your progress or your results would remain like that. Do something which you have not been doing so far. So for example, in case of labor prioritization, try doing the tasks which are lengthier. Ask your study buddy or your friend or a partner to give you a lot of findings when you're practicing. So if you only do what you can do, you'll never be more than what you are, the famous Master Shifu quote. So please remember to do everything possible to master this. Practice. That's the only way out to understand how to put yourself in this 10 minutes. So there is a lot of apprehension around labor board because people always think the labor board time is not enough. To be very honest, this is not an enigma and there is no black and white rules for this. Just like how our obstetric patients present. You need to know, like in regular practice, you might get only 2 minutes to skim through everything and decide in less than 10 minutes. So it's the same thing which you have to repeat during your exams. So whenever you see the 2 minutes board, probably there could be issues which they could have mentioned, like NICU not there, consultant not available, whatever. So make a note of that. Okay. And next thing is rooms. It could be 1 to 10, it could be 1 to 13, whatever. Just read, skim through quickly. Screen in 2 minutes what has been given to you. Okay. So ideally, if I've been given 2 minutes to read, the first thing I see is, okay, I know in the candidate instruction, this is a labor ward prioritization. I know it's a structured discussion. The next thing is I'm receiving handover at either 8 a.m. or 20 hours. Please remember, if you're not very happy with the 24 hours format, you need to make sure that you turn your mobiles and watches to 24 hours format. Okay. Either they would be giving you that you are receiving the handover at 8 a.m. or at 20 hours. And the staff available they would have given you. And if there are any issues, either they would be giving you in the beginning or they would be giving the end. And there's a list of your rooms. Okay, this is how the normal labor room board goes. So first see what time you are receiving the handover. The importance of this is in the night. You know, you have a skeleton of staff, so you might need to be very vigilant. Morning, you have at least plenty of staffs. But issues, NICU not there, means always think, okay, if I have so many preterm babies, what would I do? Consultant is about to leave home, but you have an emergency. Ask him to stop. Ask him to wait. Our consultant is busy in complex surgeries, you need to call, second on call. So the thing is to have a helicopter view of what it is. Okay. Then in the 2 minutes, when you see these 10 rooms, you see room 4 and 8 is very urgent, like the baby shoulders are stuck and there is somebody who's throwing a fit. In these cases, rest of the rooms you feel that 1 to 10, rest everything is routine. Start with these rooms. Again, where would you go? Where would the consultant go? Obviously, shoulder dystocia, you would never know it is bilateral or unilateral. So you send your consultant there. Eclampsias you can manage. So always remember there will be 2 to 3 emergencies. So always think in highly complex cases, you will send your consultant and rest you will go. So now coming back to how would you start this? You know that 1 to 10, you cannot miss the urgent rooms. If at all, if the board is evident like that, start with the urgent rooms. And then go from 1, 2, 3, 4. You should help the examiner to mark as well. And every row, always state these 3 things, guys. What is an urgency? Whether it is an urgent, semi-urgent, routine rooms, You can say top urgent, but urgent rooms are urgent. There is no top urgent or the priority or whatever. Okay, who will go? That's must. Either ST4 or ST2 or ST1, whatever. But remember, your anesthetist is there to help you to get your emergencies settled, but at the same time, they have their jobs as well. So you cannot say for an obstetric hemorrhage, I'll send my anesthetist and I'll go somewhere else, because he can only manage the head end. But obstetric hemorrhage, whether atonic or traumatic, anesthetist won't be able to help. So in those cases, you have to send one of your colleague along with the anesthetist. What they will do, you have to be saying whoever going, ST1 going, GP trainee going, what they will be doing, you have to be explaining. So these three are vital components of every room. Okay, now few responsibilities, because I think some of you are really worried of what an ST5 can do. So that's the reason I have put it here. Obviously, you are a leader who you can supervise, you can maintain the proper documentation of the records, procedures, you can do almost the complex cesarean sections, you can suture the episiotomies and lots of minor procedures you can be doing. But if you get, for example, a 4-degree tear, it's better to do it under consultant supervision. So that's the reason I have given this. And midwives. This is a common question which I get, what a midwife can do. Midwife can take the deliveries, they can put an IV access, they can actually give Entonox and Pethidine, but they cannot give epidural, they cannot do FBS, which we used to do before, they cannot do an instrumental delivery. But they can take the normal deliveries, all those things, any complex deliveries, they might not be able to. Initial newborn assessment, initial a bit of resuscitation they can do, rest everything, they would be needing the expertise. SHO are probably an ST1, what they can do. They are well versed in the basic procedures. They can draw the bloods, they can document, they can arrange for the blood, they can inform people. And some of them could take a straightforward delivery. Those are the junior doctors which you need to be aware. So what you need to be knowing is the staff, whoever is getting anesthetist. Anesthetist would help if somebody is collapsing, they are able to take care of the ABCs, and PPH, they are able to take the head end. As I mentioned before, make sure if it is a PPH, you need an obstetrician to be around, whoever your obstetric colleague you need to be sending. So don't say that, okay, I will ask my anesthetist to go and have a look into the observations. No. For example, you have a patient, you have a very busy labor ward board and you have a patient with severe headache, okay, 28-week or whatever. You can send your anesthetist because he can settle down before you. It could be CVT, it could be eclampsia, it could be anything. So choose your, your colleagues wisely. And generally, all the labor ward board, there is a one-on-one midwifery care. So you have already the midwives there, okay? Now, obviously, the labor wards can be routine. From the outset, they could be urgent. But when you start speaking, routine could become evolving scenarios, which could become urgent, which could remain routine also. Urgent rooms can become evolving and can become more worse, or they can become routine. So it's very important. For example, when a routine becomes urgent, you're supposed to be escalating and telling, now this is an urgent room. Now we will be doing this, okay? So signpost and stress on that. So we know that you are talking about, you are somebody who has a situational awareness. Now, different rooms. Please remember, labor ward board is not only about the labor ward is also about, you are the leader in that shift. So you will have the waiting room, you will have the HDUs, you have the midwifery-led units, you have a postnatal care ward. And sometimes somebody is there in the pre-op wards also, they could be there. All right. So the waiting room. One of the most important things, waiting rooms always have a look if there is an emergency. For example, somebody cannot pick up the fetal, midwife says that she cannot pick up the fetal heart rate. So you need to be sending a doctor to arrange, if at all, if you're stuck. You need to if they are waiting for ECV, cerclage, always apologize once you get in and explain what would you do. It's very important to cover all the rooms, guys. Next, you have a high dependency unit. High dependency unit, if they are saying PPH at 4 a.m., okay, somebody who had a PPH at 4 a.m., it depends what time you are receiving your handover, whether you are receiving at 8 or whether you are receiving your handover at 20 hours. Okay. So very, very important, the time at which you are receiving the handover. Obviously, if they are at 4 a.m., so you would need to go back and see, check your observations, and you need to know the findings. And based on that, you have to be re-escalating the urgency. If somebody had delivered yesterday night and she had a PPH, always talk about documentation, debriefing, the duty of candor and debriefing the team. So those things, right? And if something evolving urgent, obviously somebody who was admitted, she throws a fit, obviously that's a very obvious urgent case. When you have a postnatal care, high BMIs, generally somebody is delivered and they say that, okay, now trickling, now she's pouring, or a BMI of 48, 50, 60 has delivered. Always ask for what is the analgesia she's on, because you need to talk of VT prophylaxis. So if somebody is on epidural, you know that VT prophylaxis you cannot kickstart, right? So, and also along with that, breastfeeding and the mental health support, things like that. When you talk about the midwifery-led unit, very, very important. See, we are talking about alongside midwifery-led unit. So if you have the 10 rooms or 12 rooms or whatever, so in that probably 2 rooms could be midwifery-led units. Ideally, you will not be entering the midwifery-led unit unless you've been called in. And few things, there is no CTG in midwifery-led unit. It will be intermittent auscultation, and analgesias are purely Entonox or max to max pethidine, no epidural. And consultant-led care unit, transferring them to consultant-led care unit is a discretion of the patient. Okay. So whenever you have been given a midwifery-led unit, do not ask what is the CTG like. You need to ask how is the baby's heartbeat, because there is no CTG there. Okay, so, and you won't say that I will go and review the patient. You will talk to the midwife. If you have been called in, you're supposed to be going in. However, you are alerting your team members based on the requirement, either the consultant or the neonatologist. And one thing you guys should never forget, okay, there are 2 people who are very important in the labor ward board other than your own team members. That is neonatologist, okay, and anesthetist. These 2 people are very vital, so always make them your friends. Okay. Fine. Let's move on. For example, one of the tasks could be this, that you are receiving handover at 20 hours today, and you see that in the HDU, there is a primary para who had a BP of 160, 110, cesarean section then yesterday. So ideally, I don't want to read like this. I would want to read, okay, so the post-op patient who is in HDU had a severe hypertension. You don't know whether it is preeclampsia or not, who has delivered 24 hours back, rather than reading it out. So can I know her observations now? What's her blood pressure looks like, and what's her platelet count and LFTs, as well as the urine protein. If you don't ask this and assume, because you are receiving handover today 20 hours, if you assume it is high blood pressure and you talk about everything, doesn't make sense. Once you ask this, the examiner might say that her blood pressure is 130/80, urine protein is nil, all the blood tests are normal. Then you must say that, yes, now this is a routine case. Definitely, I would need to see this patient after my emergencies are over, and we need to look towards step-down protocol, right? Because if somebody is in a critical care, you need to be moving them down based on all other things. So you have to look into what antihypertensive she's there, and you need to repeat the things, and from 24 hours, because already 24 hours are over, and next 24 hours, you will think of this. And obviously, you will talk about VT prophylaxis, breastfeeding, and the post-op monitoring of the blood pressure as well, and postnatal care as well. Okay. So what I mean is, you don't assume. Many times what happens, people tell about everything. They assume it as severe preeclampsia. Even though she's delivered, they would tell everything. And later on when the examiner says about the findings, you are going back and talking again another 1 minute. So it will be like 2.5 minutes for one room. So to save the time, it's always better to ask for observations. Okay. Like as I mentioned, what exactly you are looking at. Now, last 2 times they had given, along with the findings, the examiner tend to give a FBS findings, even though we know that the NICE doesn't recommend, but it is not completely removed, guys. So you must know the values of pH and as well as lactate. What would you do if you have this? So that's the reason I have given this. Obviously, if it is abnormal, you're going to expedite the birth, correct? And these are the values which you need to be knowing. Less than or equal to 7.20 is abnormal. 7.2 into 7.24 is borderline. More than or equal to 7.25 is normal. Actually, the pH falls. From normal to abnormal, pH falls. But from lactate, as we know, the higher the worse. So pH increases. Lactate increases from normal to abnormal. pH falls, lactate goes in an opposite direction. Know these values well. And what would you do? If it is a borderline with a CTG abnormal, borderline FBS values with CTG abnormalities, continue the CTG, start the conservative measures. You have to be repeating FBS no more than 30 minutes. Within half an hour, you'll repeat. If pH is normal, but you did for an CTG abnormality, continue monitoring and repeat the FBS after 1 hour. So it's very vital and important to make sure that you measure this. Okay, and understand what is the value, because it would be part of the task. And labor ward is tricky because they can assess you 12 different cases in the span of 10 minutes. That's why it is tricky. So read, understand, listen, let the examiner speak, analyze, and then only speak. Okay. This is a very common thing which they give, room 1 kept for cleaning. So don't skip and go. Don't skip and go think that, okay, this is nothing. No. You should always ask for why it is kept for cleaning. Generally, these are the 3 things which they give. Legionella. It is kept for Legionella cleaning, or sewage pipes are broken. Sewage pipes means the fecal material could be spread over. So E. coli and all those things are MRSA. So for all these things, the standard answers would be, even if you don't know the route of transmission, you need to be saying that I would be informing the Hospital Infection Control Committee. I wouldn't be shifting the patient till the swabs are negative. I need to make sure that my labor ward coordinator is aware of that we cannot shift this to this room. That means to say, you might have a shortage of the rooms. Specifically for each of them, Legionella, it's water and airborne as well. So you need to see if water pipes are interconnected, and obviously if there is no water pools to be avoided, water births to be avoided, and make sure that the samples become negative. Sewage pipes E. coli, you can apply for the same principle there. When you come to the MRSA, obviously it's a hospital-acquired infection. Figure out how the patient is doing. See which are the health professionals who come across this, who have been tested or not. So you can say few things, but you are supposed to be saying things. Otherwise, you will be losing the mark on that. Okay. So whenever you see, ask if why that was kept for cleaning. Was there any particular infection which they were worried about? Okay. Generally, this is how your task would be, that you have structured discussion, you are receiving handover at 8 o'clock, 1 midwifery care, ST2, ST4 anesthetic registrar, consult in a clinic 2 floors above. So I don't find any problems because almost everybody is there, and in the morning you have people around. When you see here, see the cleaning, I said I need to be asking, but let me skim through what is quick. So I can see this is cleaning, the second degree, there's a preterm labor, again empty, episiotomy suturing. Labor referred for fetal heart abnormalities. It is not fetal heart rate. Okay. Then I have a patient in high dependency unit. Okay. And I have a midwifery lead unit, 4 cases. I have a waiting room, 4 cases. So I don't see any issues except for the high dependency unit. Okay. So either I have 2 choices because it's the middle. Either I can start room-wise, or I can finish my high dependency unit and then go room-wise. Okay. But each room, I'll make sure that, for example, this room, I would say that I can see the room 1 is kept for cleaning. Is there any particular infection we are worried about? They would be saying that. Then you would go on. Okay, that means to say, I need to inform my hospital infection control committee. Need to make sure that the labor ward coordinator is aware of this room is blocked. So whether we will have problems in putting the patients across, as well as based on the organism, you talk about the routes of transmissions. Whenever you see this, Julie, 29-year, post-delivery, Jehovah's Witness, waiting for suturing observation stable. I won't be reading it like this. I would just say that a postpartum Jehovah's Witness lady who has been waiting for suturing, no other concerns. Any observations which I should be aware of, and what is the quantified blood loss, and is her advance directive given? So they would be giving the findings. Either they would make it like, yeah, she's pouring. Then I would need to say that, okay, this is an urgent case. I'll involve my consultant first, and I need to look into her notes. IV access is there or not, what the blood and blood products she can take. And definitely I would start communication, resuscitation, arrest of bleeding, and monitoring together. And I need to make sure that whether she's okay to take the blood and blood products. So particularly that, and you start with the pharmacological method, and then that. With the third dose of 15-methyl PGF2 alpha, you're supposed to be shifting her to the theater first for the balloon, then stepwise devascularization, artery goes to hysterectomy. So, I'm just giving you a flow, how it goes, and obviously you'll be sending the consultant, okay, and the senior midwife. Or if the labor ward coordinator, midwife coordinator is there, you will be sending them. So what I mean is, I don't want you to read 28-year breech presentation, 28 weeks, no? You need to be saying, breech presentation, preterm breech labor, who is in labor. You don't know the parity and all, if it all has been given. You need to be making sure that you cover, you summarize, and then go. I don't want you to use this S-bar format, but at least I don't want you to read what is given. Then when you come for the midwife-related units, again, you need to know about any observations which I need to be aware. Dicor and amniotic twin, you need to be knowing about the presentations. Here, thick meconium silica. So how does the intermittent auscultation, how is it going? Remember, it is midwife-related units, right? This I already mentioned before. And waiting room, for example, this one. I will prevent shoulder dystocia, history of previous. You don't know what is the gestation. And whether this patient understands the recurrence, it is tenfold, still she wants, things like that. And for example, here I will for increased ST ratio. So you need to know why it is increased. Steroids given, what is the gestation, whether there is any preeclampsia, things like that, right? And you will be asking the midwife to shift to the consultant-led unit if possible, because of it's a high-risk pregnancy. Again, once they shift only, you'll be able to do that. IV access, group and cross match, and informing anesthetist, informing neonatologist, alerting your consultant based on the presentation. So guys, in simple words, understand these things very well. One of the most important thing is read the instructions very carefully. The time is important. What time you're receiving a handover. Issues you need to be locating. The staff you need to be aware. And as well as you need to skim through very quickly. I'm not a great fan of wasting time on opening sentences. I would be checking allergies, I'd be checking Jehovah's Witness, I'd be doing that, I'd be doing this. It is not wrong. Problem is you are running against time. Do you think if you do not talk about a latex allergy, somebody who is there for induction of labor, but you said for all patients I would do this, you will not be marked, right? So it's very important that don't waste that 1.5 minutes. Then for each case, these are very important don'ts, because if you know what not to do, then what to do is easy. Summarize the case. Don't read out as it is written, because the examiner can read. Yes, this is very important. What I've seen is, one case is given, people go on and on and on and on and on. And then once it's stopped, examiner is going to give the answers, the observations, whatever the scenario. Again, you have to start. So the problem is, per room, you can't waste 2 to 2.5 minutes, because you have only 10 minutes. And you will at least have 8 to 10 rooms. So that's why it's important to summarize, Ask questions like the observations, the vaginal examination, whatever you would want to know. Please do not talk about vaginal examination two things. One, as you know, placenta previa. Second one, in cases of preterm labor, pre-prom, you would only do the speculum examination based on the gestational age. Time management. I've seen people speaking 4 minutes about one room. If there is a PPH, there's so much to talk. How much ever you speak, there is a minimum number or a scoring for each room. So doesn't matter if you have 10 rooms, but you have spoken about 3 rooms in depth, doesn't matter. It doesn't help you, because as an ST5, I want you to be a safe doctor for all the 10 rooms. So I don't know what you're going to speak in the next 7 rooms. That's why manage the time very well. Any emergency, max 1.5 minutes. 1 minute is particularly enough. But if you want more, 1.5 minutes, not more than that. And every single room, you need to be doing urgency, who will be attending that room and what they will be doing. Because it's important to make sure that every single room you get this so that the boxes get ticked. And once the examiner starts talking, do not interrupt, because he has a list of findings to give you. So let him do his job. Once he finishes, then you speak. And most important, I've seen people panting for breath and going so fast that the examiner doesn't understand. Take a deep breath, talk slowly, make sure you mention the important points, and always remember to give pauses. I know you have 10 minutes, but you can easily do if you follow these rules. What should I be doing to make this perfect? Practice every day. You are going to the hospitals, or you have lots of books, or if you are students with us, you have a lot of labor ward board to practice. Practice every day. Keep a timer of 2 minutes. Ask your StudyMRCOG partner or examiner, colleague, whoever doing with you, to bring the twists and turns. What to do in 2 minutes? Practice. Take a pen and paper and start writing in 2 minutes what you want to do. One thing is, definitely make sure you understand what is the time, 8 hours or 20 hours. That's important. Have that situational awareness. Always look for the staffs, look for the issues. Rest of the things, the labor ward board won't be stuck in front of you. So you can have a look and speak as well, not a problem. If you want to take more than 2 minutes in the exam, it's absolutely fine. But you tend to get tense because everybody is inside except you. And once you sit in front of the examiner, if you feel you need a minute, introduce yourself and say that, can I take a minute before we start? They would be happy, rather than going and sitting and just looking into the paper. Okay. Practice face-to-face with your juniors, friends, colleagues, whatever. Enact the scenarios. Very important. Keep the timer on. Keep a timer of 9 to 9.5 minutes to practice them. Make sure to practice the detailed one. As I said, let your study partner give you a lot of scenarios, a lot of history, a lot of findings evolving, so it makes your life easier. And obviously, if somebody is already with us 100% in all the live circuits, in all the online, offline, we teach you this. So the best way to get the fear out is to practice. And for me, this has always been a very easy one, because if you have a situational awareness, if you know what to be done in emergencies, then you are safe. Only thing when the direct mark says, when you make urgent rooms routine rooms urgent. It has to be always balanced, because you cannot make somebody who is having PPH, you cannot say that's a routine. At the same time, you cannot make somebody who had a 3rd-degree tear, she's not bleeding much, it's okay. You need not make her urgent again. So routine shouldn't be urgent, urgent shouldn't be routine. Because as an examiner, they would be looking at whether you can manage their cases well. Okay guys, so hope this one has made your life a bit easy, because this is a task, whether you like it or not, everybody would get it. So just practice and I'm sure you will do very, very well. Wishing you all the very best. Just focus on doing the things, talking slowly, managing your time and holding on to the situational awareness. Your job is done. All the best guys. Thank you so much.